my talk is tubular spine surgery indication and execution in cervical pathologies. So we have been doing this using microscope and tubular system for last 2 decades now. And these are basic fixed diameter matrix, X-tube and quadrant that I use in my practice. Of course, we use it in all cases of lumbar spine, single level discs through 14 millimeter through multi-level stenosis, T-lips, contralateral approach to facet synovial cyst, intradural tumors. But MIS in cervical pathology is slower to gain traction because of smaller working space and catastrophic risk of cervical spinal cord injury. MIS anterior cervical approach is complicated by great vessel anatomy. There is a risk of dysphagia and phonation issues, and as such it's a muscle splitting approach. So anterior approach has not been that popular. In MIS posterior cervical approaches, the most commonly performed is MIS posterior cervical laminoforaminotomy. Rest all has been described in literature and very few people are into it, like MIS cervical unilateral approach with bilateral cord decompression, MIS cervical lateral mass fixation, MIS pedicle screw fixation, MIS cervical standalone facet joint cages and MIS C1 C2 fixation. So I will describe all one by one. The first one being more popular, I describe that in detail. MIS posterior cervical laminoforaminotomy and discectomy. The basic concept is a targeted fragmentectomy. It's basically a disc preservation, motion preservation surgery without an expensive implant. So it's minimally invasive, so reduced approach related morbidity, minimized tissue trauma, less operative time, less analgesic requirement, shorter hospital stay and without compromise in outcomes. So there are all principles of keyhole surgery here. So the ideal candidate is like this kind of patient who has got a soft disc, foraminal disc herniation. Like this, the cord is not compressed, the root is compressed and there is a soft disc. The radiological results are excellent, like this is pre-op patient, the same patient post-op. You can see excellent decompression in axial as well and very minimal footprint. So this is one of the very popular MIS approach and it's well published as well. So this is a systemic review and meta-analysis comparing MIS posterior cervical foraminotomy versus ACDF and disc replacement. And this meta-analysis concluded there is no clear superiority between posterior cervical foraminotomy and ACDF or disc replacement in terms of operative time, length of stay in hospital or rate of complications or revision surgery. This is another publication which compares MIS posterior cervical foraminotomy with tubes to prevent undesired fusion, a long-term follow-up study, and they mention no difference in outcome versus when they compare it with the fusion. Next is unilateral laminotomy with bilateral decompression. In a lumbar spine, it's a very popular approach, like this is a lumbar canal stenosis. You do unilateral approach with a bilateral decompression, and then the same has been described in a cervical spine as well. Like this patient with a focal cervical myelopathy, under a navigation guidance here, this author had done ipsilateral approach with bilateral decompression and post-op MRI showing adequate decompression. MIS cervical lateral mass fixation has been described. So bilateral lateral mass fixation can be done through a single midline incision. The advantage is it preserves posterior ligamentous attachment, posterior tension band is preserved, reduces postoperative pain. The limitation is you can use maximum 2 or 3 levels, and because of the smaller diameter of tubular retractor, you may be struggling to connect the rod. MIS cervical pedicle screw fixation. This article has been published by Umesh Srikanta and group, and they did it with a routine fluoroscopy, cadaveric study and report of 6 clinical cases in which he described this case with a C4-5 myelopathy and doing with this quadrant retractor, cervical pedicle screw fixation, decompression and fixation, and you can see excellent result. And another case they described is C3 lateral mass Cox. The lesion is excised using tube, and through the tube only they placed pedicle screw fixation, and you can see excellent results. So this can be done. MIS pars screw, pars repair with the leg screw has been described with bilateral smaller incision and direct repair of pars has been described. Posterior percutaneous facet joint fusion. Facet joint fusion has been described by Professor Goel for treatment of cervical spondylotic myelopathy and radiculopathy. The concept has now progressed to percutaneously placed posterior cervical facet joint cage. Like this patient with a cervical myelopathy with extensive facet degeneration on CT scan. Posterior approach unilateral approach with bilateral decompression had been done, and this facet cages percutaneously has been placed. MIS C1 C2 fusion has been described in a literature. So in a prone position, this kind of bilateral paramedian incision of around 3 cm lateral to the midline, this preserves the posterior tension band, and under C-arm or O-arm guidance, one can put cervical lateral mass and C2 pars or pedicle screw fixation. You can see it is using for rheumatoid C1 C2 instability, C1 lateral mass fixation, C2 pedicular fixation, and excellent alignment has been achieved. This case with a odontoid fracture, C1 C2 posterior fixation again has been done with a bilateral paramedian incision. Here again advantage is you are using natural corridor on both sides. It preserves posterior tension band, and postoperative neck pain would be reduced. MIS anterior cervical approach has been published by Dr. Arvind Kulkarni and group, and they reported technical use of tubular retractor in anterior cervical surgery, and they reported this case where C5 corpectomy and fusion had been done using a tubular retractor. Another case they described is 2-level ACDF using tubular retractor, and you can see excellent placement, but this again is very limited use and very few people are using this approach for anterior. Literature also described anterior odontoid screw fixation using tubes. Transoral odontoectomy using a tubular retractor has been described in the literature. Even MIS intramedullary tumor has been reported, but again, as I said, this kind of advanced surgery in a cervical spine is limited to literature predominantly, and majority of these cases have been done through this. This is very good article. This is another good article, lateral mass fixation. So to conclude, MIS in cervical spine is still in infancy, except MIS posterior cervical laminoforaminotomy. To progress beyond that requires advanced technical skill, understanding of MIS principles, and out-of-the-box thinking and courage. And I look forward to see more and more adaptability for wider range of indications in coming years. Thank you.